Hi, I'm Tori and I am a doctor of physical therapy who specializes in pelvic dysfunction, which means I treat things that can go wrong around the pelvis, and this includes the different types of pelvic organ prolapse. I've gotten a number of requests to make different videos surrounding the topic of prolapse, especially exercise-based videos, and I've been hesitant to create that content because it has been my experience that the right treatment for prolapse really varies person to person, and that sometimes going straight into doing lots and lots of Kegels, which is what I think a lot of people think that they should be doing, can actually make the prolapse worse instead of making it better, depending on the person. So I wanted to make a more comprehensive video talking about anatomy and the different kinds of prolapse, common symptoms, and treatment options. And I wanted to talk a little bit more about why doing lots and lots of Kegels isn't always the right call, in hopes of empowering women and people with vaginas to gain a better understanding of their bodies, what's happening during prolapse, and what kind of options they have for healing. As always, timestamps and links to any resources mentioned can be found in the description below. And without further ado, let's get into it. Let's begin by reviewing the anatomy of the female pelvis. So this is a woman who is standing in this direction and who has been cut down the center. You can see her pubic bone is here towards the front of her body, and her tailbone is here towards the back of her body. Then we have the three pelvic organs sitting on top of their respective tubes. Her bladder is here, living on top of her urethra. Her uterus is here, living on top of her vagina. And her rectum is here, living on top of her anal canal. The bladder is where urine, or pee, is stored, and when she pees, that urine exits the bladder through her urethra and goes out into the world. The uterus is where babies grow and where our periods come from. When a woman gives birth, the baby exits the uterus through the vagina and then goes out into the world. And finally, the rectum is where poop is stored, and when a woman poops, that poop exits the rectum through the anal canal before going out into the world. You can also appreciate the pelvic floor, represented here in red. The pelvic floor is a group of muscles that live beneath the pelvic organs. You can imagine them as almost a hammock connecting from pubic bone to tailbone that act as support for the organs that live above them. With this anatomy in mind, we can start to name and talk more about the most common types of pelvic organ prolapse, which are cystocele, uterine prolapse, and rectocele. Now, the medical term prolapse is truly meant to describe the descent of an organ through its respective tube, whereas the medical suffix cele is meant to describe a sort of bulging or pouching. So the term cystocele describes the bladder falling down and backwards into the vaginal canal, sort of pouching or bulging into the vagina. You may hear this diagnosed as a bladder prolapse, and technically that is a misnomer, since the bladder isn't descending through the urethra, but is instead pouching into the vagina. But the term bladder prolapse still gets thrown around in the medical community. You may also hear the term urethrocoele, which is meant to describe the urethra falling down and backwards into the vaginal canal. Urethrocoele often occurs in tandem with cystocele and is sometimes referred to as cystourethrocoele. But all of those terms, cystocele, bladder prolapse, urethrocoele, and cystourethrocoele, are meant to describe the bladder and or the urethra falling down and backwards and pouching or bulging into the vaginal canal. A uterine prolapse is meant to describe the descent of the uterus through the vagina, through its respective canal. And if you've had your uterus surgically removed, you may hear the term vaginal vault prolapse. Vaginal vault is the medical term for the top of the vagina or the top of the vaginal canal. And sometimes the top of the vagina can become lax and start to descend down into the vaginal canal. Finally, rectocele describes the rectum falling down and forward into the vaginal canal. Sometimes physicians will call this a rectal prolapse. However, this is also technically a misnomer, as the term rectal prolapse is meant to describe the rectum descending through the anal canal, not pouching forward into the vaginal canal. I think having this understanding of anatomy and what's actually happening in the female pelvis with prolapse makes a lot of sense out of the symptoms that someone with prolapse might experience. Someone with prolapse might experience a feeling of heaviness or a feeling of fullness in her pelvis. She also might be able to actually observe a sort of bulge or pouching in her vaginal canal, or just might be able to see some unfamiliar presence within her vagina. She might also have low back pain, and that's because the pelvic floor is actually a part of our deep core system. It works in tandem with some deep abdominal muscles in the front of our body, our diaphragm, and some deep muscles that line the spine, that live in the back. And sometimes when the pelvic floor is compromised, other sets of muscles in that deep core system will work overtime, like those back muscles, and that can cause some low back pain. A cystocele might give someone difficulty fully emptying her bladder because urine can collect in the part of the bladder that is pouched backwards, leaning into the vaginal canal. She might have to lean forward or even rock when she's urinating in order to feel fully empty. Similarly, a rectocele might give someone difficulty fully emptying her bowels because the stool can collect in the part of the rectum that is pouched forward into the vagina. This person might need to splint or use a finger to apply external pressure between the vagina and anus and sort of push the rectum back into that optimal positioning to fully evacuate. This person might also need to lean backwards or rock in order to feel fully empty when she's having a bowel movement. Finally, if the urethra is involved, someone might experience leakage or urinary incontinence, especially during transitional movements like sit-to-stands. And that's because an unsupported urethra can kink in a seated position, kind of like a kinked hose. And then when the person stands, the urethra straightens, it unkinks, and ends up releasing a little bit of urine. So when it comes to treatment, all treatment options are primarily focused on returning the organ to its optimal position by improving the support of that organ inside of the pelvis. Before we talk more about the different treatment options, let's first discuss how the organs are supported inside of the pelvis. We briefly mentioned the pelvic floor, which is the group of muscles that support the organs from the bottom of the pelvis. But it's also important that we mention the ligaments, which give the organ support from the top of the pelvis. My favorite way to visualize these two kinds of support are to imagine that the organ in question is a docked boat. The boat is supported by two things: the water underneath it and the ropes above it that hold it in place and tie it to the dock. The pelvic floor acts as the water in this example, supporting the organ from below, and the ligaments act as the ropes, supporting the organ from above. So then, when it comes to treatment, we can either target the pelvic floor, the ligaments, or both. Pelvic floor physical therapy, which is the most conservative treatment option, is going to target the pelvic floor because there really isn't anything a pelvic physical therapist can do to restore rigidity within the ligaments. And that's because we think that once ligaments are stretched, once they gain that laxity, that's it, that they don't recover. That's why someone who rolls their ankle tends to roll it again and again, because once those ligaments are stretched, That's it. With one exception, the hormone relaxin. If you are pregnant or breastfeeding and navigating a pelvic organ prolapse, that means that you still have the hormone relaxin fluctuating within your body. And relaxin is the hormone responsible for making your ligaments very loose, very lax. And if you look at this through the lens of vaginal childbirth, this makes so much sense because you want your pelvic bones and your pelvic organs to be loose. You want them to be able to move and get out of the way and accommodate you as you deliver a child, as you deliver your baby. And the thing about relaxin is that it is going to stay in your system for up to 6 months after you stop breastfeeding. So know that your ligaments are going to continue to regain rigidity. They're going to get firmer, which means that your prolapse is going to continue to improve for up to 6 months once you stop breastfeeding. So a pelvic physical therapist is going to work with you to improve those pelvic floor muscles, to improve the support of the organs from below. And a good pelvic physical therapist is also going to work with you to alter different aspects of your lifestyle, to implement different lifestyle changes that are going to help optimize your body during recovery. Generally speaking, the areas of your life that are going to need to be evaluated are the ones that could potentially be related to bearing down. Think straining during bowel movements like constipation, think heavy lifting, think coughing and sneezing, and even at times you can consider weight loss. When you inhale, hold your breath and bear down. You create a lot of downward pressure in your pelvis, which pushes the organs down and isn't very good for prolapse, especially when you're trying to heal. And generally speaking, when it comes to weight loss, the less weight you're carrying on top of your pelvis, the less downward pressure in your pelvis, the better for your prolapse recovery. A second, more conservative treatment option is a pessary. A pessary is a device that is inserted vaginally that helps to better support the organs and helps to hold them in a more optimal position. I am a big fan of pessaries, and while I can't prove it, I do think that it might be true that long-term pessary use actually does improve ligamentous rigidity. And I've seen women use pessaries in tandem with pelvic physical therapy interventions and have wonderful outcomes as a result. The pessary gives both the pelvic floor and the ligaments a break as they off-weight the pelvic floor and take some stretch off of the ligaments. They can be used all day, every day, or they can be used sparingly, only during provocative activities. While pelvic physical therapists can't fit pessaries here in the United States, we can help you figure out when to use them, how long to use them, and how to pair them with the right pelvic floor exercises and lifestyle changes to optimize your results. The third and final treatment option is reconstructive surgery, which is going to aim to optimize the position of the organ inside the pelvis by improving its ligamentous support. Surgery will either use mesh in order to recreate that ligamentous support, or it will staple the organs onto uncompromised, otherwise healthy ligaments inside of the pelvis. I am not against surgery, but I will say that one of the beautiful things about prolapse is that it usually isn't a medical emergency, which means you have the gift of time. Please recognize that I am biased. I do tend to lean more towards natural and conservative treatment options, so do take what I say with a grain of salt. However, if it were me, I would use that time to fail all of my conservative treatment options before I opted for surgery. Sometimes surgery is great and it improves quality of life significantly and the long-term outcomes are wonderful. And other times surgery isn't so great and it decreases quality of life and the long-term outcomes really aren't so wonderful. Any reconstructive surgery that uses mesh deserves your thorough research and understanding before you commit to the actual surgery. And while the statistics do vary, about 33% of these reconstructive surgeries do fail within 5 years' time. And I think that might be because any sort of pelvic floor dysfunction isn't addressed and no real lifestyle changes are implemented in order to protect the outcome of the surgery. So if surgery feels like it is the right choice for you, please do consider pelvic physical therapy as a rehab option in order to help you better protect the outcome and longevity of your surgery. All right, I do want to share a little bit about the way that prolapses are graded. Prolapse is usually graded via the POPQ, or the Pelvic Organ Prolapse Quantification System, which consists of a scale from 0 to 4, where 0 is no prolapse, normal, and 4 is very severe prolapse that requires surgical intervention. So this view of the vaginal canal that you are about to see is as if someone were facing forward, facing you, and they've been cut right down the center, cut in half, but in this direction, cut right in half through the frontal plane. This represents the vaginal canal, and this represents the uterus, the organ that is being used in this example. Usually, if someone scores a 1 on the POPQ, they don't know that they have a prolapse and are asymptomatic. 1 describes descent of an organ to or above the upper half of the vaginal canal. A grade 2 is given if the organ is 1 centimeter above or 1 centimeter below the level of the hymen, which means the organ is either still inside of the vaginal canal, but it is in the lower half of it, or the organ is just visible outside of the vaginal canal. A 3 is given when the organ is visible outside of the vaginal canal and is more than that 1 centimeter away from the hymen, but it is no further than 2 centimeters less than the total vaginal canal length. And finally, a 4 is given when the organ protrudes further than 2 centimeters less than the total vaginal canal length, and this is known as complete eversion and does require surgical repair. Usually, someone with a grade 2 or a grade 3 is who I see in the clinic and who I find benefits the most from pelvic physical therapy, pessary use, or both. We usually see an ascent, an improvement of half to a full grade with that conservative treatment. However, we're never really aiming for a specific grade so much as we are trying to drastically improve or completely eliminate all of these symptoms associated with that prolapse and trying to get the person back to doing whatever activities and things it is that she loves without having to worry about prolapse. It is also incredibly important to remember that these grades aren't fixed, that gravity is going to affect the grading system. For example, if your doctor's appointment is at 8 a.m. and all you've done that day is gotten out of bed and gotten yourself to your appointment, you're going to get a much different grade than if your doctor's appointment was at 4 p.m. and you'd been on your feet all day doing activities, grocery shopping, going for a walk, what have you, and gravity has had time to have an impact on your prolapse. All right, now that we have discussed anatomy, the different kinds of prolapse, symptoms, treatment options, and the grading system, let's talk a little bit more about why I don't think that doing a bunch of Kegels is always the right thing for everybody. The primary reason is because of something called muscle length or muscle tone. Let's use my bicep as an example of what I'm talking about. So, in order for a muscle to be strong, it needs to have full access to its range of motion. It needs to be able to get really long and get really short. And a palpable example of this using your bicep would be trying to lift something up when you have access to your full range of motion versus trying to lift something up when you only have access to the very top of your range of motion. So give me a second, I'm gonna show you what I mean. All right, so I've got this drawer, this little container. It's kind of heavy, it's got notebooks and things in it. I think you can imagine that it is much easier for me to lift this up when I have full access to my biceps range of motion than it would be if I tried to lift this only with the top of my range of motion. If I tried to lift this only with the very top of my range of motion. But the reason that it's so much harder for you to lift something up when you only have access to the very top range of your biceps range of motion is because when a muscle is short in this way, when that muscle length is compromised, the muscle is functionally weak. So now, if you can imagine your pelvic floor in your mind's eye, just imagining that hammock connecting from pubic bone to tailbone, you can imagine that one response to prolapse, one response to an organ descending onto the pelvic floor would be for that pelvic floor muscle to contract, to try and hold a contraction, tighten up and get short in order to support, in order to lift that organ. And sometimes pelvic floors will forget to let go and they'll almost fall into a sort of spasm. And when that happens, it is incredibly important that we focus on lengthening the pelvic floor before we work on any sort of strength. Because, as you can imagine, if your pelvic floor is stuck at the very top of its range of motion, and then all you do are a bunch of Kegels, not only are you not going to be helping your pelvic floor, but you might accidentally, even though your intentions are so good, make the pelvic floor spasm worse. A second reason that I don't think that doing a lot of Kegels all the time is always the best intervention is because your pelvic floor is actually made up of two different kinds of muscle fibers, fast twitch fibers and slow twitch fibers. In my head, I like to think of fast twitch fibers like sprinters. They're on and they're off, whereas the slow twitch fibers are much more like marathon runners. They are on and steady for long periods of time. They're used much more during endurance-based activities. And your pelvic floor is actually made up of more of those slow twitch fibers than it is of those fast twitch fibers. It's about 70% slow twitch fibers. And the reason for that is if you think about the pelvic floor and the different functions that it has in the body, like supporting the organs that live above it, the majority of those functions have much more to do with endurance. If you think about organ support throughout the day, that isn't something where the muscle is going to be on and then off. It's something where the muscle is going to be on, holding steady and enduring. That organ support is much more of a slow twitch fiber activity, whereas a fast twitch fiber activity might be protecting you when you cough or making sure that you don't leak urine, making sure that you remain continent when you jump. Finally, my last hesitation surrounding not wanting to do an exercise video is because sometimes people don't need a lot of cues in order to figure out how to actually isolate and contract their pelvic floor, and other times people need visual cues, verbal cues, and tactile cues, and just a lot of coaching before they can actually get that contraction isolated and correct. And so I worry a lot about form. It's unfortunately really easy to do all sorts of different types of compensatory movements instead of true Kegels, true pelvic floor contractions, because you can't see your pelvic floor. Again, Kegels can be right for some people sometimes, 100%, but that isn't always the case, and that's why I really do feel that it's best to seek the guidance of a provider who can assess you and your pelvis and tailor interventions to your unique body. So, if you have prolapse and are interested in seeking treatment through a pelvic physical therapist, which I hope that you are, you can find a link in the description below to a directory to help you find a provider near you if you live in the United States. Before I end this video, I do want to remind you that you are not alone in your experience at all. Prolapse is much more common than you might realize. It affects at least a third of women sometime in their lifetime, and that statistic only reflects reported cases. It is very treatable, and while the right treatment does vary from person to person, you are so deserving of that treatment and of your healing. I'll quickly add too that a common question I get a lot in the clinic has to do with whether or not it's safe to have sex when you have a prolapse, and the answer almost 100% of the time is yes, it is safe to have sex with a prolapse. I can make a different video about that. In fact, I will, and I'll link it here and I'll put it in the description below. And I also have a really quick and easy technique that you could use if you're having symptoms after going for a long walk or doing some sort of other provocative activity that can really help alleviate that feeling of pressure, that feeling of heaviness. It's super easy. It takes like 5 minutes. I'll make a video about that and I'll link it here and I'll put that in the description below as well. I will get to making both of those videos ASAP for you. And on that note, thank you so much for watching. If you found this video helpful and enjoyed it, please do give it a thumbs up. And if you didn't like it, give it a thumbs down and let me know what I can do to improve in the future. Please feel free to comment absolutely anything down below. Feedback, content suggestions, questions you have, criticism, really anything. I do try really hard to read and respond to all of my comments. Don't forget to check me out on Instagram. And finally, if you'd like to see more content from me, please do consider subscribing to my channel. I make content about pelvic things, like today's video, and I also make content about life things. Thank you again so much for watching. I hope that you have a wonderful rest of your day, and I will see you in the next video. Bye.